This presentation is going to cover items for your assessment of the reproductive system. Okay, so we're going to start with menstruation and some key terms here. Menarche is going to be the onset of menstruation. So at what age did the client start their first menstrual cycle? It can be quite irregular for the first 2 to 3 years, and then it should become regular. If not, then we might need to look into some other issues. So the first 5 to 7 days of the cycle is that menstruation, when menstruation occurs due to the uterine lining that's breaking down. After that period of time, the uterine lining thickens again, and then followed by your ovulation, usually around day 14. So this is halfway through the cycle. And then you have your uterine lining continues to thicken until it breaks down again. Amenorrhea is going to be when the client does not have a menstrual cycle, so there is no active bleeding, so that uterine lining is not going through this cycle of increasing thickness and then breaking down. So it could be a multitude of things that may cause this. Exercise, stress, hormones, so it may need some further follow-up. Dysmenorrhea is when there is pain during or shortly after that menstruation period, but is not the same as premenstrual syndrome, PMS. So PMS is when that painful period of time actually is interfering with lifestyle and work. This isn't simple cramping and distortion, pain. This is severe. Often this is not just a few times. It may be every cycle. It may be every other cycle due to the different sides that are ovulating. They rotate once a month. And then your last key term here is going to be menopause. So that is when menstruation cycles are no longer occurring due to the absence of hormones. So the female reproductive system, first let's talk about screenings. So when someone comes in at different ages, we want to make sure that they're getting appropriate care, and we're looking for those abnormalities. So when discussing with the client, we're going to ask questions during our history taking that hint at and trying to observe if they might be participating in any type of risky behaviors, any type of eating disorders or depression. These can definitely affect menstrual cycles and risk for carrying diseases. Also, we need to be aware of abuse, intimate partner abuse, signs and symptoms of those, as well as being very mindful and very cautious of approaching someone that may be in one of those situations. Also, mutilation, genital mutilation of the female can occur, and if it is noted, we should not bring attention to it. But if it is new, we definitely need to have an intervention. And any indications of sex trafficking, of course, need to be reported. We also need to ask about sexual activity and any recommendations that we might need to give to them about using contraceptives and preventing sexual transmitted infections. That we'll go over, I think, on the next slide. Also, the female should perform breast exams monthly. Now, it's important that when they do this, it's going to be that week after menstruation, so about a week after their flow has stopped. So this is around the time of ovulation. This is when the hormones are at the most consistent level and going to be consistent every month. Hormones can play a role in breast tissue and how it feels, moves, and things like that. So comparing from month to month is going to be key so that you know what any new changes. Here's a video here about breast self-exam, BSE. Okay, so some steps that break that video down. There's the link here to the National Breast Cancer Center, Breast Cancer Organization, and gives a very similar breakdown in step formations. Also, the females should have a pelvic exam every year, beginning when they are sexually active, and a pap smear beginning at age 21, if not prior to, if they are also sexually active, or they have additional risk behaviors in their history when we do their history taking. A mammogram should be done at 40 years of age, or of course earlier than that if they have additional risks in their family for breast cancer. And we should recommend receiving HPV vaccinations. This is usually a series of 3 vaccinations starting at age 9 and then again at age 26. Next, we're going to discuss some sexually transmitted and vaginal infections. So we have sexually transmitted infections. These could be definitely, of course, present in both female and male. So we have chlamydia, gonorrhea, syphilis, HPV, and genital herpes. These are all transmitted through sexual contact. They have various infection and inflammation signs and symptoms. I would not focus on the differences of signs and symptoms at this point, but recognizing that when these are recognized or identified, that they should be treated immediately. Vaginal infections are going to include pelvic inflammatory disease. So this is inflammation due to an infection in the pelvis and inflames the area. Awesome. And can be quite painful to the female. There may be not any other signs or symptoms except for pain during intercourse. So that may be their only sign, and that may eventually lead them to seek care, but they may just abstain from sex for a little while. But often this needs to be managed a little more closely. So there's some education for pelvic inflammatory disease that we need to make sure that we're aware of and to provide to our clients. Trich and yeast infection, the candidiasis, are infections that are quite similar, but it's a different type of organism. So trich being bacterial and yeast being yeast, but have very similar reaction to the cervix, but the post reaction is going to be the difference in the discharge. So trich is going to be that green mucus looking discharge, whereas a yeast infection is going to be white, milky. It may be even yellow. Bacterial vaginosis is going to be also quite similar, white, yellow, thick, cottage cheese looking. So it's important to know history and recent sexual practices to figure out and diagnose this. Of course, they will send a sample, but initial treatment for recognition of their signs and symptoms. And then group B, strep. We definitely want to screen for this. It is one of those that is quite asymptomatic, but can be quite detrimental to a newborn during intrauterine development. So it is one of those that we do screen every mother for in their prenatal care. Now, male reproductive screenings. So similar to the female, we have the breast self-exam. For the male, we're going to educate about testicular self-exams. So there's this website here that gives more information about testicular cancer, but just the initial information for how to perform it. So first you're gonna, not you, but instruct and give education to the client about doing this also once a month, just like with the female, but the hormones in the male do not fluctuate, so it can be any time of the month. Usually we encourage this during a warm shower or just after a warm shower, and they should cup one testicle at a time using both hands preferably, and then roll between their thumb and their forefinger using slight pressure. It should not be painful. And then identify the spermatic cord and epididymis, and feeling for any lumps or changes and irregularities. One testicle should be, or most likely is going to be slightly larger than the other, but any drastic change, of course, in that month should be reported. Any pain should also be reported, or any lumps should be reported. Now, testicular torsion may happen after a strenuous exercise. Any type of minor injury to the testicles can actually also occur during sleep. But most common when we see this is going to be when the male is maturing and their testicles are descending. So the spermatic cord traps the testicle, and therefore blood flow is no longer being free to flow into the testicle to provide circulation to it. So anything without circulation will die quite soon. So this is a medical emergency, should be seen in the emergency room as soon as possible, and usually require surgery to reduce this circulation issue. Now, next we're going to talk about infertility. There's many reasons for infertility. A lot of testing must be done to identify exactly why, especially if they are wanting to figure out the exact reason, which can be quite expensive in today's culture. So it's not just the male or the female. In most cases, in quite a lot of cases, it's both. So you see here, it's kind of, and there's a lot that are still unexplained. So in those cases, after testing, they figure out if it's from the male, if it's from the female, or if it's from both, or they still can't figure it out. There are options if they still want to become pregnant. They can consider sperm or ovum banking. So such as if the female has infertility, the male can bank their sperm and transfer or have a surrogacy or things like that, so that is still part of their genetic makeup, but the female cannot carry it long enough, or that her eggs aren't receiving the sperm correctly. There's different reasons at what stage of the fertility process that causes the infertility. So they may both still be able to use their sperm and their egg and transfer the gamete to someone else, or if it's a structural problem that it's put together outside of the body and then transferred into the female. So it was just an issue of the sperm going up to the ovum at the top of the ovaries and descending down into the you know the word I'm trying to say. So if it's a structural problem, it can be also transferred. There are also hormones that can help the female and the male if that is one of their problems with their infertility. And of course, they can always seek a donor or surrogacy, but not always, because it is quite expensive. Next, contraceptive. So contraceptive is are things that will stop conception, the formation of a fetus. So anything that is going to interrupt the sperm and the egg from meeting. So condoms, of course, are going to be one of these contraceptives. Diaphragms, cervical caps, so these are barriers. Sometimes they do have hormones on them, but not necessarily. And then of course we have hormonal methods, so birth control, otherwise known as the pill. They have to take on a daily basis about the same time every day. And of course, if days are missed, then they don't have that hormone, and therefore, especially during their cycle, during that ovulation period, they could become pregnant. There are options for emergency contraception. So either they did not use a condom, or they're missed a few days on their hormonal method. There is the option for the emergency contraceptive. So there's a combination of high levels of hormones that are delivered and administered to the female. Sometimes it's quite a few pills. It can, because it's a high level of hormones, there are quite a few side effects. They could have nausea and vomiting, diarrhea, flushing, allergic reaction. There's many different things here. So of course this is a last resort. We would prefer and educate clients to use the other methods for contraception. And then there are invasive or moderate and actually invasive procedures that can occur to produce contraceptives, so like IUDs. So that's the little T-shaped device that is going to be inserted and secrete hormones so that the hormones prevent the passage of a live sperm so that it does not impregnate the egg of the female. And then of course sterilization, so a tubal ligation for the female or a vasectomy is going to interrupt those from being produced. Now, there are other ones discussed in your book and noted on this poster about the calendar method and cordis interruptus and spermicides. These are options. They are available to the public. They are not as reliable, though, as the other contraceptives. Okay, the last thing we're going to talk about are abortions. Now, there are many unsafe abortions that occur in the world. Nearly half of all abortions worldwide are unsafe abortions. So 1 out of 3 unsafe abortions occur in the worst conditions with untrained persons and using dangerous methods. So there is a big push by the World Health Organization in promoting safe abortions. Again, as nurses, we are in a role of we don't involve politics and we don't involve cultures on our behalf. We are there to promote the health and safety of our client. So no matter our position on abortions, we have to support what is evidence-based practice for our clients. So evidence-based practice, if they are to seek an abortion, we want them to have a safe abortion, right? So WHO are promoting many policies and practices to reduce those barriers so that more females are able to acquire safe abortion and girls around the world to avoid the dangerous and which can be quite fatal to many females as a consequence of an unsafe abortion. Now, there's different types. So you have elective abortion, which is the one that is commonly talked about nowadays. So this is something that the female chooses to do with no without a medical indication, whereas there's the therapeutic abortion. So there's a issue with the pregnancy that it could be life-threatening for the mom as well as the fetus. So they will choose and opt for the therapeutic abortion to save their life. And then we have types as in the procedure. So we have aspiration abortion. So while in that position, the lithotomy position, the medical professional suctions out the fetus and all the contents, and afterwards can be quite painful. We're going to, of course, educate for post-operatively when they leave, or if they are seen in the emergency room shortly after. We want to make sure that they are watching for excessive bleeding. It can be a complication for hemorrhage. Avoid douches. It's a very sensitive, already shed layer of tissue. We don't want to irritate that even more. That can actually induce bleeding again. And then we're going to give education for contraceptives and other alternatives, so birth control and other things, so that they hopefully do not resort to another abortion, especially in a short period of time. That scarring can lead to many issues later in life. So education is going to be key. And then the medical abortion is when medication is given to the client in order to expel the fetus. But of course, high level hormones, so nausea, vomiting, diarrhea, headaches, dizziness, fever, and chills are definitely seen in the period shortly after for about 2 to 3 days. It is normal, but of course we need to make sure that they are recovering effectively. Hydration, signs and symptoms of bleeding, they're going to have all of those same education as well. Okay.